your presentation after the introduction.
Okay.
And then me and Dr. Charles whenever he's on. And the most important here, I think, is to highlight the main topics and issues, and so we can discuss later with all the leaders here. Já podemos? Can you start, Mariana? Is it open already? Okay.
Okay.
Alexandre.
Hello, everyone. My name is Alexandre Ferreira Oliveira.
Peraí, doutor Alexandre, o técnico vai começar, e aí na hora que aparecer, aí você pode começar. Ele disse que está configurando.
And Felipe, as you request, I'm going to keep my lecture short, around 10 minutes.
Okay.
You can have more
Yes,
time for
yes,
discussion.
yes. Okay, perfect. You can extend a little bit, of course, don't worry. I think the most important is just to be sure you will you tell us everything you think is important. So.
Okay. Sure.
Hello, everyone. My name is Alexandre Ferreira Oliveira. I'm a general surgeon, a surgical oncologist, and a president of the World Society of Surgical Oncology. First of all, I would like to thank to all the participants, Dr. Charles Baus, President, the International Society of Oncology Prevention and Treatment, Dr. André Carvalho from the International Agency of Research on Cancer, AIRC, Dr. Felipe Coimbra, Secretary of WSSO, Paulo Henrique Souza Fernandes, President of BSSO, Dr. Gerard Bitts, President ESSO, Dr. Gaston de Lama, President of Peru Society of Surgical Oncology, Dr. Mauro Guilovissa, representing Mozambique, Dr. Sérgio Aguilar, representing SMO, and Dr. George Cliff, President, German Society of Surgical Oncology, who are responsible for our second webinar, whose theme is the surgery role for early diagnosis to curative treatment. This topic reflects the very core of our society's DNA, at the center of which is our patients. How often does not have access to early diagnosis? Even after overcoming the diagnostic stages, patients must still find a reference center with qualified surgery capable of treating a disease that claims the lives of 1/3 of those affected by it. Well-performed oncology surgery remains the main form of treatment and diagnose almost all types of cancer. At this moment, I would like to give the floor to our Secretary General, Dr. Felipe Coimbra. Felipe, please, Felipe.
Thank you all. Welcome to the WSSO second webinar. And so this important topic, we would like to share our ideas and how we believe this is so important to patient care and the whole society, and not only for surgeons. So we understand that the surgeons play a critical role in the patient care and the complete journey of the patient. Sometimes we and maybe others can see like the surgeon as one only a single step in the whole journey of this patient. So I'd like to discuss this, and maybe it's very common that we always complain, right? So the patient comes too late to us, so you can't operate then. They don't come, and why? Né? So this is, I think, one of the main questions here. They don't come because they have many barriers. They don't come because they come too late. They don't come because they don't do the early diagnostic detection, and why it happens, and what's the role of the surgeon on that? Should we keep only complaining, or should we actively, maybe we can do some more together here, and including all this patient journey on our surgical discussion. I believe many here are all people, friends here are leaders in surgical oncology and cancer surgery. all around the world, in all the continents here. We have important institutions. We have Andrea representing early detection and prevention from YARC. We have Dr. Gira Dietz from ESO. We have more than 30 countries represented here today. So there's a good opportunity. And the idea is to, at the end, of course, we take all the main points discussed and raised here, so we can have maybe a position paper or something to start the discussion on, and then keep this movement going on pretty well. So thank you very much for being here, for participating, and hope you can help us to spread all this message and all these important topics here. So I think we could then start with Dr. André de Carvalho. It's a great honor to have me here. I know André for many years already. He's not only a friend, he's very engaged in the cause of cancer since the very beginning. He's also a researcher. He's a surgeon. And so he understands very well. And now he's working, he's the head of early detection and prevention and infectious disease, right? At YARC from World Health Organization. And so we invited him. I think it makes a lot of sense to include him in this discussion. And so I'd like to invite André to give his presentation and share with us the main points and how he understands and how he sees this whole discussion for us. So thank you very much, André. Thank you very much, all participants here today.
Thank you so much. Hello to everybody. It's a pleasure to be here. Thank you so much for this kind invitation from WSSO and through Felipe. As Felipe commented, we know each other for a long time. Just as a background, I am originally from Brazil, and we are contemporary at the residence time at AC Camargo with Felipe. And I ended up doing surgical oncology and then specialized in head and neck surgical oncology. And I remember when I started as a resident and a young, staff, that 80% of the cases of oral cancer were advanced. And that means at least, a mass of over 4-6 centimeters in the mouth, that came, too late because either nobody thought about the diagnosis or the system didn't help for the diagnosis. And this one of the first research I did was trying to understand the late diagnosis. And I have been a head and neck surgeon for 18 years. And then the number, decreased from 80% to 70%, right? So at that point, I realized that change will not be done at OR. There was the change needs to go to the health system, that to the root of the problem. And I thought as a surgeon that I could act on that scenario, so I decided to go to public health and now in global health, trying to change in another aspect of the early diagnosis. And that's this kind of invitation to share some thoughts here with you. I'm gonna start my presentation. Please let me know once you have my slides presented. Is that okay, the presentation?
It's okay.
Okay.
It's okay.
Yes.
Okay.
That's okay.
Okay. So for those that don't know much about the International Agency for Research on Cancer, we are WHO specialized in cancer research. And the idea is that we do the evidence base for cancer prevention and control programs, while WHO take those evidence and translate those evidence in policies. And this is kind of the complementary role that IARC and WHO have in cancer control. In the middle term strategy, we can see the emergency priorities, and one of them is implementation research. And that's, I am at IARC for 6 years now, and that's my main focus, how implementation research can change prevention and early detection of cancer. So we're moving a little bit more towards the implementation, as of what we have been known for so long for the Globocon, the estimatives of incidence and mortality, and the monographs and handbooks and the blue book for pathology, and try to, bridge the gap on how we implement the changes and that evidence. And then when we talk about that, I think the major synthesis that we have been put it, and in Europe we have been doing these, for already, in the fifth edition, is the codes against cancer. So the European Code Against Cancer is in its 5th edition, and says that in Europe there's 14 ways for you to prevent cancer, and these could prevent 40% of all cancers. So this is very powerful, but to implement this is quite difficult. But it's a few things we have been good at, like vaccination, is something that we do. HPV vaccination for cervical cancer is being doing more and more, and the organized cancer screenings. Some things a little bit more difficult when we talk, about diet, about physical activities. But anyways, if we could implement this in full, we could prevent 40% of the cancers. And we also realized that those codes are regionals, right? So we are going now from regions, and on the left side, on the right side, you can see the Latin American and Caribbean Code Against Cancer, and actually that became 17 ways, to prevent cancer in Latin America. And we can see that when we talk about screening and early detection and prevention, we are talking about colorectal cancer, breast cancer, cervical cancer, but also gastric cancer in Latin America, and lung cancer in the European Code Against Cancer plus gastric cancer. So one concept also that I would like to discuss is the difference between screening and clinical early diagnosis, right? Because we can act in both as surgeons. So the early detection is an umbrella that includes screening and early diagnosis. And for the screening, we are taking the asymptomatic population, putting a screen test, and try to identify among those that has a screen test positive, those that has no cancer, those that can eventually have a pre-cancer. And if it's for cervical and colorectal, we can eventually prevent invasive cancer by treating the pre-cancer lesions. And some of them are going to have invasive cancer. When we're talking about early diagnosis, we are talking about giving awareness of the signs and symptoms of cancer. And for those that are symptomatic or think that they have some issues, they want to come, majority of them will not have cancer, and some of them are going to have cancer. It's really more hard to find the pre-cancers when we talk about symptomatic people, and it's more likely that we have advanced cancers when we talk about symptomatic people. For some cancers, we can do both, right? For cervical, breast, colorectal, gastric, and lung, even prostate. But for a lot of them, we can only do early diagnosis, right? Regardless of what is the pathway, if you're talking about the screening or about early diagnosis, there is the pathway and there is the delays, right? And usually we treat those delays in 3 types of delays: the access delay, the diagnosis delay, and the treatment delay. And I'm going to try to bring attention how surgeons can affect and decrease those delays in all the stages. So for the access delay, we're talking eventually when you have symptom until you got through the first visit. But if you're participating in a screening program, this starts when you do the screening test. But once you have a suspicion of cancer, either because you went to the doctor or because you did a screening test, there is the time that's taken for you to confirm that diagnosis of cancer. And then when you have a confirmed diagnosis, there is the time until you start your treatment. Health systems and countries have different time delays and different struggles when you talk about this referral pathway. And also we can see the barriers here, right? That when we talk about access delay, we're talking about poor screening initiation system, poor cancer awareness and health literacy. And when we're talking about the health system, from this from the symptoms at the screening test until treatment, we are talking about suboptimal performance of the health staff, quality sorters, the pathway referral issues, the waiting list, limited diagnosis and treatment resources. And regardless of any, there are a few things that is across, right? The financial obstacles for patients, medical and non-medical costs, logistics, practical and geographic barriers, cultural and psychological barriers. So it's a very complex system if you think that you have this triage about the patient, the health professionals, and the health system. And to coordinate all of that is one of the reasons that we have late diagnosis. So how can surgeons how IARC is trying to bridge this, and how can surgeons play its role? So IARC, as you said, we work with prevention mainly, primary and secondary, meaning, what we can prevent cancer and what we can do for early diagnosis. We do not do a lot of studies in curative care or the clinical, but we do care about the clinical implication of it, right? We need to understand that when we try to do early diagnosis, and that was commented by Alexandre Oliveira when he started this, that if you do not timely do a diagnosis and timely do a proper treatment, right, you lose the opportunity. So if we bring some patients with early diagnosis, but the treatment is suboptimal, we might not gain the advantage of that the early diagnosis could get in the survival of the patient. So what are the steps and what are the major bottlenecks or the broken links in this pathway, right? So the step one would be to do prevention and risk reduction, right? We're talking about, the codes against cancer to reduce late presentation. And here, surgeons can promote primary prevention, but advocate for better pathways for the symptomatic people, right? We do have the early recognition referral, right? What are the symptoms and screening that would trigger rapid workup? And we should work on how health professionals that are the first point of entry, that might not be a surgeon, that might not know, be a specialized in cancer, would identify symptoms that can be related to cancer and accelerate the referral of the suspicious disease. One of the major points after this is how to get in diagnosed, right? So that we're talking about diagnosis staging and doing a triage of what would be the treatment. So we're talking about biopsy, pathology, and imaging. We have an issue of access, but also when you talk about pathology, in so many countries around the globe, there is a shortage of pathology and also a shortage of proper imaging that would allow to proper clinical staging that would lead to a proper treatment. So how can we also do something that's quicker, right? How can we train surgeons to do guided biopsies using, portable ultrasound, low resources, possibilities that don't make the patient go to big centers to get the diagnosis that. How can we better access quickly the resecability and to support the multidisciplinary team discussion, right? And then we come to the curative treatment, right? That includes surgery and or systematic and radiation that's delivered on time, but also is delivered as a standard treatment. How can we promote that? And finally, the surveillance. And the major factor, as I comment, is around the diagnosis and initiation of the treatment. Just as a few examples, right, that comes with some projects that IARC participate. When I came here, the ABCDO project from a group at IARC had identified a huge gap in survival in Africa, in 5 countries in Africa, while the white Namibian woman would have 9% 5-year survival, while the others would have, 36 to 58. And even when you adjust for clinical stage, some of that was clinical stage, right? the survival was poor, meaning that, and then when they identify was that even localized non-metastatic cancer, the multi-modality treatment was far from universal. So the given of standard treatment was not happening, right? More than 30% of the patients with breast cancer did not undergo surgery. And another 1 out of 3 of women abandoned that require chemotherapy did not start or did not complete the treatment. And that put the survival, even for those minority of women that got early diagnosed, lower than what you can see for advanced cancers, for breast cancer in the North Hemisphere. So then again, you lose that ability that what we're trying to bring, that early diagnosis will lead to better survival because you're not promoting the adequate treatment. You're not being able to perform. So downstaging is necessary, but mortality gain is blunted when treatment quality and continuity are weak. And that's the message, because that's a huge point that surgeons can act upon and get the advantage of the early diagnosis. It's different when you talk about the high resource setting for the low resource setting. So globally, we see this huge gap, right? When you have suspicions to diagnose in the high resource settings, you have a seamless referral to dedicated breast or thoracic radiology units to make the diagnosis. While in low resource settings, you have a fragmented diagnostic capacity. Patients are lost of follow-up, and there's long waiting times and not proper quality of those imagings, right? The tissue acquisition or the biopsy, it's routine rapid core needle biopsy performed by specialized interventional radiologists in high resource settings. But in low resource settings, we are trying even to promote the breast ultrasound and ultrasound guided biopsy that are essential, but sparsely available, creating a massive bottleneck in the diagnosis part, right? And the surgeon's endpoint, right? The enter of the pathway primary after stage is complete to perform the operation. While, in low resource settings, there is a pull for the role of forward for prevention, the patient attrition. And the surgeons needs to help to close the gap between these to make it the best of it. So these also is quite important for us to keep in mind. It's easier to talk about early diagnosis when you have a high resource settings than when you have a low. So as we try to summarize a little bit and try to bring some experience, right? There is going to be a lot of patients with suspicions of cancer, right? But in a lot of countries around the globe, the biopsy and pathology is a bottleneck in terms of access to imaging, access to the biopsy, access to pathology, proper diagnosis when we talk about immunohistochemistry, even more when you're talking about the genetic markers and others. And then only after that, the surgeon can really perform what they're training to do, right? The surgical interventions and start the treatment. But if surgeons should also think about how they can decrease the struggle and facilitate the access to biopsies and to diagnose and facilitate the staging, so you can implement treatment as fast as possible and also coordinate a proper oncological treatment. There's some evidence that bringing diagnosis afterwards in the ABCD, for instance, in Uganda, all the cancer diagnosis were done in a single city. That's Kampala. That's the capital of Uganda. So some women would need to go 250, 500 kilometers to get the biopsy. Some of them will not have cancer, but most of them will, because there is a late stage presentation as well. We have been trying to train surgeons to do diagnose with portable ultrasound and handheld portable ultrasound in secondary level hospitals, and not only in the big hospitals in the capital, so we can shift the diagnosis from a single place, a single center. So this is kind of decentralized, democratizing diagnosis in some places is the first and the most important bottleneck that we can act, right? And then what is the best way for staging for breast cancer? We're trying to see, some molecular markers can be done cheaper than immunochemistry, even though because you don't have the proper pathologists or the proper technicians to do the immunochemistry or to interpret that, right? And surgeons can promote that if they're part of the diagnosis pathway. So if you think about, when as I was training the surgeon to be, the captain of the ship and the multidisciplinary team to try to coordinate the things, if we do one step before, and go even before that, we might change it. And this is becoming even more important when you're trying to move cancers that usually presented in late diagnosis for early diagnosis. But the window of opportunity to treat them while in the early diagnosis is very short. And this is coming more and more true for lung cancer, right? So this is results from the Nelson trial in the Netherlands. And in the blue, you can see that for the screening arm, they have, 50% of the cancers is in stage clinical stage 1A, another almost 10% in 1B. If you compare to the control arm, the majority is stage 3 and 4. And this is not only the effect of the clinical trial, because if you compare to patients diagnosed in the regular cancer register, they follow the same pattern of the control arm. So screening does make a difference, right? And that's what you can have regarding survival in both of the largest clinical trial for lung cancer screening. Stage 1 and 2, you can promote, you can give 65 to 80% 5-year survival. As you go for stage 3 and 4, even more for the 4, that goes for less than 10%. But if you don't treat the patient right away after the diagnosis, they're gonna because they're diagnosed asymptomatically, they're gonna very fast become stage 3 and 4, because that's what we usually see when the patient is symptomatic. And then you lose the opportunity of curing them, and then screening doesn't make sense anymore, or because you're losing that. So the whole idea that, when you do screening with low dose for lung cancer, you have over 60% of the screening stage 1. But you need to do a rapid workup, a timely standard treatment, otherwise you lose the game for the survival. And if some of the, high resource settings are struggling to do that, and I'm participating, trying to implement lung cancer screening in some countries, right? And you have some countries in Europe, right, that have the financial means, but have only 2 thoracic surgeons in the whole country. Right? If we think that lung cancer is a treatment for curative treatment is about surgery, and they're about to start, screening, they're gonna need to think about how they're gonna deal with the increasing the volume of the surgical cases. That's what you want in the end. So, and then as we move to the last part of the surgeon's, role in that is how, you coordinate the multidisciplinary team to promote, that patients that came with early presentation get the proper treatment and the coordination of the sequence. And I think this is also another place that the surgeons can play an important role. To summarize, right, there are 5 steps that when we talk about the whole pathway, and surgeons can have an important role in all of that. When we talk about prevention and risk reduction, instead of even talking about early diagnosis, we're preventing cancers to happen, right? And surgeons should promote primary prevention and advocate for pathways for that to happen. We're talking about early diagnosis, right? It starts with early recognition and referral. Surgeons can accelerate the referral of suspicious diseases. We're talking about diagnosis, staging, and what we're going to do in terms of treatment. Surgeons might perform guided biopsies, assess resecability, and support MDT's decisions to accelerate this process. When you talk about curative treatment, we know that the most effective curative treatment in cancer is surgery, right? So we should think about how we could deliver definitive resection and nodal assessment and promote for those that needed the adjuvant, neoadjuvant, or concomitant treatment as needed. And then we have also, the follow-up and survivorship that surgeons close the loop on the treatment quality. So division prevails. Prevention is the anchor. Downstaging is not enough. Screening works for some cancers, but as soon as we got the diagnosis early, we need to timely promote standard oncological treatment. So surgeons should not be just operators. They are pathway facilitators who act across the continuum, promoting guided biopsy when is needed, assessing operability and deliver definitive resections and protecting the continuity of care. With that, I'd like to thank you so much for this opportunity. And I'm going to stop here. Thank you.
Thank you very much, Dr. André Carvalho. And this is was a very concise and complete. It was an excellent presentation. Thank you very much. It really highlighted many important points here so we can discuss. I will ask if you could present all the three presentations, and then at the end, we have a group of panelists that will make questions and comments, and will help us to understand how it may be very similar or very differently all over different regions of the world. So thank you very much. Now I think Dr. Charles Balch has arrived, right? So it's an honor to have Dr. Charles Balch here. He's a very good friend, a very well recognized, renowned surgeon all over the world. He's one of the only surgeons that have presided medical oncology, ASCO, Medical Oncology Association. He's also from WSSO and many other institutions. He has worked on, and he's now the president and founder of the ISOP, the International Society of Oncology and Prevention and Treatment, which we believe is key on this cancer organization and engaging many surgeons and oncologists and all the specialties all over the world. So please, Dr. Charles, be free to start your presentation. And at the end, you have one more presentation, short one, and then the discussion and questions.
All right, can you see my slides?
Yes, perfectly.
All right, so I'm honored to be here with all of you in the World Society of Surgical Oncology and especially my Brazilian friends. I'm going to go over just a short talk, and hopefully it will be provocative to you because I want to talk about where the surgeon will be treating cancer in Latin America, elsewhere in the world in 2035. So I'm in my 50th year of surgical oncology practice. And when I started, surgery was the cornerstone. We had limited systemic options. We gave adjuvant therapy. We had very poor outcomes. But now, in the last 25 years, there's been a transformation with systemic therapy. And I think the key point here for all of us as surgeons is that in the world, in the next 10 years, surgery will not be the first treatment for most all primary stage 2 and stage 3 cancers. And in fact, if you look at melanoma, colorectal surgery, and breast cancer, we may be doing no surgery whatsoever in patients who are major responders for systemic therapy. So the point is, we have to transform who we are as surgeons and understand that neoadjuvant systemic therapy will be first for most stage 2 and stage 3 cancers, and that the type of surgery that we do in major responders is going to be de-escalation or no surgery at all, not the radical surgery that we did. Now, in the future, there's going to be more of a push for doing prevention and early detection and early stage optimization and so forth, as Dr. Curative had just talked about. And this is what I wanted to focus on now as we transform there. And the key point that I made here, surgery is no longer the first treatment for most stage 2 and stage 3 cancers. However, surgery will remain as the best standard treatment for stage 0 and stage 1 primary cancers. The third teaching point is in the next 10 years, according to the IARC and other databases, cancer will increase by at least 25% worldwide, and in some countries by as much as 100%, including some Latin American countries. So there's an opportunity for us to really start to get more engaged in prevention and screening, because as the cancer increases and as it moves towards the younger ages, those individuals right now are presenting, as you just heard in lung cancer, and I can show you some other data, are presenting with advanced disease. They need neoadjuvant therapy, not surgery. But if they are in screening programs or prevention programs, the surgeon has a major role as the primary treatment. So we as surgeons have to be actively engaged in prevention and screening programs that will enable the surgeons to be available at the time of the first diagnosis. Whoever is there at the time of first diagnosis is the one who's going to be the major influencer on what is the first treatment. And the reason I think this is going to be possible is because of major advances now in identifying the at-risk population and engaging in personalized risk assessment counseling, and then engaging the at-risk individuals in prevention and screening programs. And if we're kind of leading those discussions, then we will have an opportunity to be involved in patients when they first present with in situ or stage 1 disease or risk reduction surgery as part of their prevention interventions. So I've listed here, and this is very similar to the previous speaker, the surgeon's role in prevention and early detection, patient education and counseling. And it's not just the surgeon, but our team of PAs, nurses, and educators, genetic counselors, who can be involved in patient education and counseling. So we have to not work as a solo, but as a team in the prevention and early detection and screening programs. Then being very engaged in identifying the high-risk groups, using family history, genetic testing, and lifestyle, all of which can identify individuals before they get cancer and get them engaged in prevention and screening programs. And then third, once they're in screening programs, and as we go to governments and insurance companies and so forth, they can't afford to screen everybody. But if you can identify, which we can now, the 15 to 20% of the at-risk population and put them into screening program, there's lots of evidence in the world that that's cost effective, and it detects individuals at a lower stage, at a lower cost. It preserves their productivity and increases their cure rate. So there's a very compelling reason for all of us as a profession to really push our governments, insurance agents, the business communities, and the public to be involved in screening and prevention programs, and we should be among the leaders in doing that. It takes initiative and leadership and strategies. Then, if we're there at the time of early diagnosis, surgeons are the first line of defense for early stage cancers and precancerous lesions. And also for the very high risk individuals, there is a increasing case for risk reduction surgery as one of their prevention interventions, such as prophylactic mastectomies and oophorectomies in the breast ovarian hereditary syndrome, in the colectomies, in the Lynch syndrome, in the TP53. There's a lot of high risk individuals that can be identified among the population with currently available technology. So that means we as surgeons need to be engaged in understanding genetic testing. So I want to report to you that as of this week, I will be a licensed, a certified cancer risk assessment counselor. And I've done a 5-month course because if I'm going to be involved in prevention and screening and leading this in our society, I need to engage more in this very rapidly changing area of risk assessment and population-based genetics testing and the counseling with that. So the point is that surgeons, because we treat primary disease, are uniquely positioned to lead in cancer prevention through education, identification, and intervention. So let me give you 3 examples here. And these are my personal examples just in the last few months. We do now employer-based risk assessment. And just 2 weeks ago, we had a 32-year-old employee who was outside of the age guidelines and who, because of her family history and genetic testing, was identified as having an increased risk. She was somewhat reluctant because she said, I'm too young, but she went ahead and got an MRI. And she had a stage 1 breast cancer. And incidentally, she was pregnant. So this is a woman that, had she not had screening, would have had stage 2 or stage 3 breast cancer several years later, and her child might have been an orphan. So it shows you the benefit of identifying these individuals. In this same program, there was a 41-year-old healthy male who was a BRCA carrier and a BRIP1 carrier. Now, he's not going to get breast cancer, but he had 2 sisters and 3 daughters who are at risk and need cascade genetic testing. And in fact, we found that 2 of the sisters had inherited risk and underwent prophylactic mastectomy and salpingo-oophorectomy. So I think this just shows you where our future is going to be with current technology, which is going to get at a lower cost and be more widespread as the evidence shows the benefit of doing this. Now, I wanted to show you the opposite. This is a friend of a family member, a 42-year-old woman that I know, who presented with vague symptoms and finally went to her doctor and was found to have stage 4 colon cancer, multiple liver metastases. She has 3 young children. She will never see her children graduate from high school. And the tragedy is we found that she had Lynch syndrome. She had other family members with multiple colon polyps. And the point is, there is a population in all of our communities who are at risk for early disease that we can now identify. And that's going to need to be our future in leading that on how to do this. So the other reason this is going to be important is that cancer is going to increase because of inheritance mutations, and especially because of our environment, especially because of the obesity epidemic. And as you can see from this data for the IARC, the projected increases in cancer, and I could go through every country and demonstrate an increase in cancer in every country that in the next 10 years. So this is going to be a public health issue that is almost going to replace heart disease as a major cause of death and loss of productivity in the workforce. And I think the other point that we need to start promulgating or using as our strategy to the community, to the leaders in our government, in insurance companies, and the business communities is number one, 50% of all cancers can be prevented or cured with prevention and early detection strategy. 50%. And nearly 70% of years lost of life due to premature death can be averted by applying effective risk reduction efforts and improving access to curative treatments. We need to lead that discussion in our communities, in our nation, and in the world. And then I think, as you've heard about, we can go over lung cancer, colon cancer, cervical cancer, breast cancer, and demonstrate the benefit of reducing cancer mortality and cost and maintaining workplace productivity by entering people into screening programs. Now, screening programs today are age-based, but as the age of individuals become younger, for example, in China, the average age of breast cancer is 45, average. We're seeing always, when I do my weekly webinar in China, 25-year-old, 30-year-olds, young people with breast cancer who present with advanced disease because their doctors say you're too young to get cancer and they're not in screening programs. So here's some unsettling data that I want to show you where we're going to be 10 years from now. And as leaders of our societies, we need to prepare people for what the future is going to be. So we're not reactive, but we're being proactive as leaders. And so here's just the incidence of the rising onset of colorectal cancer. And every country has demonstrated that. And the key point here is these recent publications showing individuals born after age 1960. Look at the increased incidence in England, Australia, Canada, and the United States, and how it is increasing in men and women. And we're seeing this in the United States, as shown over here. We're seeing a decrease in mortality and incidence in the older population, but an increase in the younger population because they're not being screened. And I also had a reference here showing in Argentina, there are lots of publications about early onset rectal cancer, and this will be a coming epidemic that we all need to prepare for and be leaders in. And this is another recent publication this year going over all the Latin American countries, and it says the same thing. If you look at the rate of increase in those individuals who are young now, in 10 years, they will be a very important group of individuals showing up with colon cancer in all the countries where this has been studied. So this is just a summary that I put together about the rising cancer burden in Latin America, breast cancer, colorectal cancer. And the key point is today, because these individuals are outside the age guidelines, they're presenting with advanced cancer, stage 2, stage 3, or stage 4. And yet the tragedy is all of those individuals could have had been in prevention and screening programs 10 years earlier and been diagnosed at an earlier stage or had their disease prevented in the first place. Here's one other example.
This slide shows the early detection rate of gastric cancer.
I'm
Korea
sorry?
and Japan have much higher rate than France, largely due to the widespread screening.
So that was Kyogo Ito from his lecture, again showing for gastric cancer, where they do screening in Korea and Japan, that 50% of their patients are stage 1 and need surgery. But in France, where they don't do screening, only 6% are stage 1, and they all either die or get systemic treatment. The other reason that this is compelling, look at the difference in the cost of treating in breast cancer, stage 4 in the red lines at the top over 4 years, and stage 1 at the bottom. So for everybody paying the bills, you get a huge return on investment by putting money in the front end of investing in screening and prevention instead of paying a lot of money, expensive treatment for stage 4 disease. The other issue that I think we need to make as a compelling story for getting into prevention and screening is productivity losses because of cancer mortality. And the big three in terms of projected loss of production in the younger individuals, and I showed in the age group of 40 to 64, is the ones that are most common: colorectal cancer, lung cancer, and breast cancer. So again, as cancer is increasing, as it's occurring in the younger age group, that we're going to not only have higher costs, lower productivity that affects the GNP of each country, unless we start to lead in cancer prevention and screening. So here's the future, and this is why we can do it. We now are understanding the role of the microbiome on affecting the immune system. We're now getting more and more data every week on risk-based screening and the benefit of that, including in identifying in the younger age group. And we're understanding about the accidental genotypes, population control and population-based testing, and the issues that is going to be driving the increase, especially in breast and colorectal cancer, with the increasing epidemic of obesity, and now how that is directly connected with 14 different types of cancer. So this is just another few publications from Britain, from the United States, and Australia, showing now the future of doing risk stratified breast cancers by using genetics testing with, in this case, small panels for breast cancer risk, and then identifying those individuals based upon family history and their genetic risk, regardless of age, putting them into screening programs and identifying that you can identify in a cost-effective way those individuals at an early stage or get them into prevention programs. The other point that was published just in December, the Wisdom trial, which is a landmark trial, there's a parallel trial of the Wisdom trial where they took the individuals at the highest risk based upon their genetic testing and showed that they got into participation of prevention, of reducing weight, of exercising more, of drinking less, and of participating in screening programs than they might have otherwise, because they knew that they were at a high risk for breast cancer. So let me just finish up by the surgeon's role in prevention, early diagnosis and intervention, risk reduction, surgery, as we identify more individuals in the population in their 30s and 40s based upon family history and genetic testing to get them into prevention, intervention, chemoprevention, screening, and consideration in the very high risk for prophylactic surgery. And here's just some examples. You know this data as well, showing risk reduction surgery for colorectal surgery, risk reduction surgery for the BRCA carriers. And I even picked out one article from Chile showing the reduction in gallbladder mortality in individuals because they have such a high risk for gallbladder cancer from doing prophylactic cholecystectomy in those individuals who have stones. So here's my summary. Rising incidence in the young and middle age in all countries, including Latin America. Surgeons are the front line for early intervention. The increasing application and the lowering of the cost and availability of genetic and lifestyle risks so we can identify the at-risk individuals before they get cancer. And surgeons should drive that risk stratification. Then entering into risk reduction surgery, and us having leading programs that have to be population-based through employers, through patient advocate groups, through the government programs to get individuals at risk to understand their risk and enter into prevention and screening programs. So I want to thank you very much for the opportunity of talking to you, of partnering with the World Society of Surgical Oncology, with the Brazilian Society of Surgical Oncology, and with the International Society of Oncology Prevention and Treatment. We're all working together with the same mission, and hopefully by joining together, we can create a louder message to more people and provide leadership in moving forward for cancer prevention and early detection. Muchas gracias. Obrigado.
Thank you,
Thank
Professor
you.
Charles.
Thank you very
Gracias.
much, Professor Alexandre. Yes, okay. So
And
thank you very
moments,
much, Dr. Charles. Count on us to with the ISOP goal, and we are sure that the initiatives that have the same goal should share the opportunities and should help each other. So count on us as WSSO, as the same as ISOP, ESO, and all
Felipe,
the
I'll change my
associations.
background now.
Oh, yeah, yes. Okay.
Yeah,
Thank you.
okay.
And so this is very important. And we invite everyone and every association and every society to come together with us. We're not competing. We want really to help and help to bring this some gaps that I think talking together it's better and easier to understand. I have a few slides just to highlight some points here so we can start the discussion. Is it okay, Alexandre? I don't want to take much of the time, just to have around 30 minutes of discussion. So thank you everyone for this opportunity to have you all here. Unfortunately, we weren't able to include everyone in this discussion because of the time, of course, but we have many other opportunities to do that. I'd like just to highlight some points of the role of the surgeons across the cancer journey, but focusing on the curative therapy, of course. So the problem we don't talk, I think the previous presentation already highlighted this. So surgical excellence is not the main limitation sometimes, depending on where you are and the team you have together. As what's very well shown, fragmentation is important. The patient arrived too late, decisions happen too late. So the surgeon should be in the first moment of the decision. And the real determinants of outcomes are sometimes if you have an excellent surgeon, an excellent surgical team, and the structure, timing and coordination may be the main issues. So the first critical failure was very well shown here already. So the late surgical involvement, we know that reduced curative opportunity. So it's not only the surgery itself, but it's also all these aspects of the surgical and the patient journey around the care, the management of care. So it comes from diagnosis. André and Dr. Ball showed very well. So by the time surgical expertise is asked to evaluate, critical windows for intervention have often been closed. So this is very important. Fragmentation is a unique, important point. It's not just biology, as Newton just told us the last webinar. So this disconnection decision across specialties is a very important issue, and that's something that WSSO is starting to work on. So remember, the patient comes from the general clinician, gastroenterologist, endoscopy, for example, for gastric cancer, Dr. Domenico, you know that very well. If the patient have many barriers around all these steps, when it comes to the surgeon, it's very late sometimes. So we want to open this conversation. Not only you have a plan to do this already, and not only if oncological association. So of all specialties and inter-specialties involved on this. So the multidisciplinary challenge is very important, right? You know, there's a lack on multidisciplinary discussions and groups and tumor boards around the world. And in many high-income countries sometimes, and sometimes it may be not so effective as it should be. So that's something that I believe we should work on it. And there are many challenges on implementation. So it's not only having a tumor board, but a discussion, a multidisciplinary discussion about how to implement, how to validate it, and how to analyze the results. So actually what really changed the outcomes of the patients, to have a good team, the patients to come in the right time, to have this very well discussion. So that's the opportunity for the patients to come and to arrive at the right time. So again, time is very imperative. It was very well shown already before me today. So I think this is one point for discussion, a concept. So Dr. Balt highlighted this very well. Modern surgeons must lead in precision oncology and system coordination. So it's a coordination of the patient care, not only surgery. Because if you stay only complaining, oh, the patient came too late for me, we won't change anything. So we have to lead it. So that's our point of view. There's one point for discussion here. I'd like to understand what are your opinions. And leadership is not optional. Imagine if the patient have 10 doctors, so the endoscopist, the gastroenterologist, the radiologist, and then the surgeon, and the medical oncologist, so pathologist, who should lead this? So at least in the early cancer care journey of these patients, for the curative treatment, I believe surgeons should lead this concept of patient journey from the very beginning. That's a good question, because we don't have time sometimes to do that. We're not enough to be in all the steps, but we should help to coordinate it and be engaged in all this movement, I believe. So the continuity gap for diagnosis survivorship, it was already being discussed. So, and also to the survivorship, I think Sibeli, who is here, commented on that. So these patients have bigger, greater chance of secondary tumors. And so we should be very aware of that too. So just to raise some questions here. So the surgery must be at the center of the cancer journey, yes or no? I'd like to know your opinion. We have ours, of course, and not at the end of the curative treatment. We should be involved in everything to help to decide if these patients, the decision, the plan, we should be involved in the planning of the treatment, for example, to coordinate it and to lead it. So that's how we see it. That's how we think it's important. I'd like to understand and know your opinions. You have leaders and many friends and many surgeons from all over the world here. So, and this requires a fundamental shift in how we think about surgical oncology. So maybe the leadership, maybe try to be involved much more on this. And the surgeon, we see the surgeon as a bridge from the diagnostics to the curative treatment. So we should try to help since the beginning in some way. And so we may have the chance to bring more patients for more curative treatments. So I'd like to thank you again. And I'd like to also to invite you to join us and be part of this leadership and this movement. And also from the scientific committees and many other opportunities that will be announced very soon. So thank you very much. And I believe now we can start our discussions.
Thank you, Felipe.
And I invite Rodrigo, and if Carolina would like to help us, she's the leadership for institutional relationships from WSSO. Thank you, Rodrigo.
Thank you, Felipe. Thank you, everyone. Two inspiring lectures. Thank you, Dr. Charles Balt, and thank you, Dr. André. Amazing, outstanding talk. I'd like to invite our panelists. So we have many leaders from many countries, many different continents from around the world. We have Dr. Gerard Bitz from European Society of Surgical Oncology. We have Dr. Paulo Henrique from Brazilian Society of Surgical Oncology, our current president. We have Dr. Gaston de Lama from Peru. Thank you, Professor Gaston. We have Dr. Sergio Aguilar from Mexican Society. We have Professor Jörg Kliff from Germany. We have Dr. Iraklis Katsoulis from Greece. We have Dr. Mauro Gilovisa from Mozambique, and we have Dr. Caroline Nessing from Canada. I'd like to start asking Dr. Gerard Beets to share your comments and your insights about our outstanding lectures. Professor Gerard.
Yes,
it's a
well,
pleasure.
Thank you, Rodrigo. Well, thank you for the invitation, and I'm very happy to be part of this. The 3 lectures were outstanding, and I cannot stress how important this topic is. Usually, the surgical heroism at the end of the disease, or the very locally advanced big surgeries, they draw more attention. But I sometimes say the more hopeless a disease is, the more the surgeon gets excited. So the earlier we are in the disease, the more it benefits society, for sure. So surgeons should be a part of this. Now, it's organized differently in different countries and for different types of cancer. I'm a colorectal surgeon, so I know very well how it works in colorectal cancer. And I just want to point out that in my home country, the Netherlands, it took 10 years to set up the colorectal screening program. It started in 2014, and now we are seeing mortality going down. We are seeing much less liver metastasis, peritoneal metastasis, less chemo needs to be given. So now we are getting also the financial rewards, let's say. But it requires a big investment up front, which is maybe easier for high-income countries, but I think it's really worth the effort. We are seeing that. So it requires a big thing from society. It's a society effort, not just a medical effort. So that's my main thing. And I want to say also about we are also seeing the increasing incidence at a young age. So the reflex is we should start screening earlier, and we are going to do that. But in the Netherlands is one of the latest countries in Europe to start screening earlier, because you have to consider the financial aspects of this too. Although it is increasing, it's still a minority of the complete burden. So we are going to go down in screening, but you have to be very thoughtful about that, and you have to let the economists work that out. I have a lot more observations that I can share with you, but we'll do that later on maybe. Thank you again.
Thank you, Dr. Gerard Beets. Moving forward, I'd like to invite Dr. Caroline Nessing to share some insights and comments.
Yeah,
Dr.
so I think thank you so much again for including me. As you know, Canada is pretty small, so it's a little bit easier for us to have screening programs. There's quite a few rules that you have to abide by. We're also a very public healthcare system, so we have 4 main screening for 4 different cancers in Canada. The first one is colorectal, and that's been going on forever. Originally, it was that anybody at 50 gets a screening colonoscopy, and then depending on what they find, they have different surveillance patterns. And how this was created, hard for me to know, because from the day that I was in medical school, we've had this screening program. And actually, it's very much run by our family physicians. It's in their protocols, like they have to do these screening programs for their patients for cancer because they've been shown to prevent cancer. And so we do them all the time. So the colonoscopy one starts at 50 years old. If you have family history, it starts at 40 or 10 years younger than the youngest that got affected. Then we have the breast screening program with mammography, obviously also starts at 50, but can start at 40. We then have prostate cancer, as well as the newest one on the block is lung cancer. But lung cancer, you have to have criteria, meaning you were a smoker or you were, you have to have certain criteria to be included in a lung screening program. In terms of breast cancer and like high risk things, a little bit more like Dr. Balch was mentioning, we have like high risk screening programs for people that have BRCA mutation or things like that. Then they're allowed MRI, because the difference in our country is everything is so publicly funded. It needs to be approved that the government would pay. And for a screening program to be effective, it has to be non-invasive, very few complications, and would benefit the majority of the population. So if you don't have those three things, you're probably not going to get a screening program. Surgeons do play a huge role in screening. Every time you see a consult, you're going to ask about family history. And if you think there's a genetic syndrome going on, you're absolutely going to send them to genetic counseling. And that's very well established here as well. And so we're able to get genetic counselors to give us opinions, do blood tests, or do whatever they need to do to see if someone has a type of syndrome. But I do agree. I think screening is very, very important. That's in the very, very early stages for early cancer. And it has, probably saved quite a few lives. So I do think it's extremely, extremely important, because as much as Dr. Beets mentions, it's more exciting for us when the cancer is more complex as surgeons, because we could roll into immunotherapy and all the neoadjuvant treatments. And definitely the surgeon plays a huge role in being the organizer and the planning of the care of a complex cancer case. Even at MDT, most MDTs are run by surgeons, at least in Canada they are. However, obviously for the patients, it would be better if the cancer was avoided in the first place. And so those screening programs, how they work in Canada is you actually get a letter in the mail, and it reminds you to go do your screening mammography, or reminds you to, so they know the age of everyone. And like you literally get a letter in the mail saying, you need to go get your HPV vaccine, because that's like a new one as well. So we get letters in the mail to make sure we've done our pap test, our screening mammography. Colonoscopy has now been switched to FIT testing because it's more cost effective. So colonoscopy is done for some people, but in general, most of us do FIT testing now instead of FOBT. So they're doing FIT testing. And honestly, all of this is pretty much managed by the family physician. So a slightly different way of ensuring the population is taken care of with regards to high risk and common cancers. But I do agree that surgeons play a huge role. And I think you would have to, in your country, in order to have a screening program like that, maybe find out who are the legislative bodies who manage this. Because I think the task force that created these screening programs was probably immense. And when they first started, was not an easy task. But they did eventually get it. And now it's like clockwork. Get the letter in the mail, you make sure you get your mammography, get your colonoscopy, whatever. Like it's just part of our healthcare system.
Thank you, Dr. Caroline. Dr. Gaston de Lama, Peru. Could you share some insights?
Bueno, mi
North
nombre es
America.
Gastón Mendoza de Lama y estoy muy feliz de participar en este debate.
Well, my name is Gaston Mendoza, and I'm very happy to be here in this conference.
Y veo un enfoque distinto. Lo que se ha dicho es bastante cierto. La prevención es la parte fundamental para vencer o detectar temprano el cáncer.
I have a very different focus. Detection is the most important thing to treat cancer.
Pero, ¿por qué fracasamos?
But why we fail?
En Perú, el 70% de todos los cánceres se detectan en etapas avanzadas.
Here in Peru, about 70% of all cases of cancer are detected in late stages.
Y eso es similar en buena parte del mundo.
And that's similar in pretty much the whole world.
Tenemos programas de detección, historias hermosas, pero fracasamos.
We have beautiful detection stories of cancer, but most of them fail.
¿Pero por qué? Porque voy a hacer una analogía entre lo que es formar un hogar y el gobierno.
But why? I'm going to make an analogy between making a house and the government.
Cuando uno se casa o forma un hogar, piensa en la casa, el carro y la comida.
When you get married and you get a home, you get a budget for the house, the car, the food, but not for health.
Pero ¿cuánto de presupuesto se destina a la salud de un hogar que se forma?
How much of that budget is directed to health?
Probablemente sea cero.
Probably zero.
Lo mismo sucede con el Estado.
It's the same thing with the government.
El presupuesto de salud del Estado peruano es de 1 a 2%.
The budget of the Peruvian government here is about 0
a 2%.
2%.
Es demasiado bajo en el hogar y demasiado o casi inexistente en el gobierno.
It's too low in the home and pretty much non-existent in the government.
Porque no tenemos una cultura de prevención.
Because there's no prevention culture.
No tenemos una cultura de prepararnos para los eventos adversos.
We don't have a culture to prevent future events.
Entonces, no tenemos guerreros que luchen en la prevención, en el diagnóstico precoz del cáncer.
We have no fighters to fight against the early detection of cancer.
Pero si le damos el protagonismo, nombramos a todos los cirujanos, comandantes de la lucha contra el cáncer, lo vamos a lograr.
But if we make all surgeons the protagonists of this prevention of cancer, we will get it.
Nos falta empoderar a los cirujanos.
We lost this signal, so let's move forward for a while. So I'd like to invite Dr. Iraklis Katsoulis from Greece just to share some insights, to share some ideas about the subject here. Dr. Iraklis.
Hi, everyone. I'm grateful for your invitation to share our thoughts on these very important issues. I have really enjoyed the presentation this afternoon. I represent the Hellenic Society of Surgical Oncology. We are a society established in 1988, and we're an affiliated member of the European Society of Surgical Oncology. In this term, I'm the president of the society, and I'm very pleased to be to join you this afternoon. What we've heard are very important points on the role of surgical oncologists from the early detection of the cancer, the prevention of the cancer, the detection of the cancer, and throughout the journey of the cancer care. Just a few remarks. Of course, there are very variations globally, from high-income countries to middle-income countries and to low-income countries, very, very different variations. There are areas of the world where, due to very limited resources, the only treatment access, the only treatment that may be available for a cancer patient may be the surgical oncology, or surgery, if you like, because these people might not have any access to radiotherapy or chemotherapy or other more expensive modalities. And therefore, surgical oncologist, as we all can realize, plays a crucial role in the journey of treatment of the cancer patient. Another issue is the training and the education of new on surgical oncology, which is variable from nation to nation and from continent to continent. And there are still areas in the world, including my country, where the surgical oncology has not been yet recognized or as a separate specialty of surgery, which is another issue which probably is beyond the discussion that we are having this afternoon. In Greece, we have implemented over the last few years the screening programs. The screening programs for breast cancer and colorectal cancer nationally are running over the last few years. And we are already having our first promising results, as many cases of early cancers in asymptomatic population have been picked up. It's very interesting as in the discussions and the presentations that we've heard from Professor Bals. We've heard about the very important issue of genetic counseling, of preventive surgery in high-risk population. And this is also one of the roles that the surgical oncologists may play in preventing cancer. Thank you very much once again. Maybe later on, if there is some more time, I would contribute some further thoughts to the discussion. I'm very pleased to be amongst all of you. And I would be very happy if my society, the Greek Society of Surgical Oncology, strengthen the links and the bonds with other societies, and we may contribute to international collaborations with you and others for the good of the cancer patients globally. Thank you again.
Thank you, Dr. Iraklis. Dr. Jorg, and how about your insights and comments from Germany? Thank you for your presence here.
Well, thank you for the invitation. It was a great pleasure, and it was also, there were 3 very inspiring talks so far and very interesting discussion points. Actually, I think there are many things to discuss. What I put like 3 different points that I would like to highlight. I think what is really important is that we as surgeons are involved from the beginning of the journey. I think we have to emphasize this very strongly, because it's not everywhere the case. I think in many countries there are also other paths, and the surgeons involved at the end of the patient's journey. And we have heard it quite convincingly that it's very important to be involved from the beginning. And one of the key aspects to achieve this are MDTs. And I'm not sure that all over the world MDTs are dominated by surgical oncologists. I think there are a lot of countries, and even within my country, dominated by medical oncologists. And the surgeon plays a role, but not the main role. I think it is important that the surgeon plays a very active and leading role in these MDTs. And we have currently a structure in Germany where we have certified cancer centers, and every cancer patient has to go through an MDT before there's any treatment decision. And that obviously helps also for the patient journey, but this is not mandatory in the whole country. So there still the majority of patients not treated at these certified cancer centers. And I don't know how it is all over the world. I think one goal to improve patient care would be really to make it mandatory that cancer patients are discussed in these boards with a surgeon present to find the right treatment decision. So that would be one point to stress. Another few comments about screening programs. Obviously, we also have screening programs for colorectal, breast, etc. The experience is that even though it's free, there's a relevant percentage of the population that do not participate in these screening programs. And what we observe, for example, in colorectal cancer, we see a decrease in the incidence, obviously. We also see an increase in the younger patients. But you also see this percentage of patients that do not go to these screening programs then end up with some advanced disease at presentation. So the relative proportion of these patients is actually increasing compared to lower stage tumors. And I think for the screening programs, it's important also to have everything evidence-based because we do not have a lot of screening evidence-based for most of our cancers. And I think AI might help. There are a lot of data out there that, by all the imaging we do, ultrasound, CT scan, MRI scan, we can filter out unrelated tumor entities, diseases, just by applying AI to these images. I think that will change in the next 10 years, probably, how we do screening. And the final point I want to make, that there was some strong projection of the future where we say, well, most of our patients will not be treated primarily by surgery, but there will be neoadjuvant therapy, other multimodal therapy, and there will be non-operative treatment of tumors that we now operate. But I don't think the workload will go down because of this, because on the other side, I think we'll have tumors that are advanced, metastatic, that will be downstaged, and finally will end up with surgeons. So again, it's important to have surgery involved from the beginning, also to decide whether that might be potentially curative in the future. Because nowadays you often see patients that are, not discussed with surgeons and they're put on the palliative road, and we would disagree on occasions that these patients might be candidates even for curative treatment. So these are the 3 points I want to make. Thank you again for inviting me to participate in this discussion.
Yeah, if I could add for a second, I think Dr. Cleef has a very important point. There's going to be a whole new field of salvage surgery for these patients who go into watch and wait, and what we do in those patients, how we can maximize their survival and get them safely. I think that's a very important part of our future, and it's part of the transformation of surgery that we have to prepare the younger surgeons for.
Thank you, Professor Bauch. Thank you, Professor Cleef. I'd like to invite Dr. Sergio Aguilar from Mexico. Bienvenido.
Hola, muchas gracias. It's a pleasure to meet you. This is a great initiative. I'm very happy to be here with you. I have a sort of different vision, and it was very interesting to see the focus in developed countries on what we surgeons should do in order to control this global burden. But I think it's clear that there's a broad gap in resources and priorities between high and low and middle income countries. And given that this society is global, I think that a diagnosis of current status of early detection programs, perhaps before focusing on screening and implementing technology, perhaps, I don't know, differences in measuring metrics that we have between countries in order to identify which thing would be better as an intervention, might help us thinking more globally. I think it's great to take into account that screening is important, that technology is important, but most of the world is not high income country. We have different needs, we have different situations, we have, most of us, fragmented health systems. So perhaps I would suggest, before trying to implement something, to make a local diagnosis of, for example, early detection, which I think personally, as coming from a middle-income country, might impact more in survival than screening or technology use or any other thing. So focusing before, or in the first place, in early detection, making a local diagnosis of which things are not working in each country, perhaps even constructing a backbone of the needs globally, not specifically under certain metrics, so to say, metrics in preventing. I think prevention culturally is very difficult. Culturally, it's a barrier because every country has different needs and different people and different everything, different food, different metabolism. So having an initial diagnosis in each one of our societies, our countries, perhaps starting with the National Cancer Institutes, which we have, and we have the opportunity of making research, having this diagnosis in these institutions of all over the place, and then implementing something that we all might need, I think would be a great start. Because I know it's great, we have a lot of things to deal with, but focusing in the most important one, I would state is early diagnosis before anything else. Since when we do screening, we're hoping to find a disease in a patient that has no disease, really. If we make risk reduction, for example, surgeries, we are doing surgeries in patients that do not have a disease yet. Most of the low and middle income countries have the problem. We have the problem of having locally advanced tumors, which inevitably impact on mortality, on survival. So perhaps that would be my suggestion, and the thing I would love to share with you, to focus perhaps on early detection, make a diagnosis with a real global focus, with the needs and the situations of all of us, and afterwards perhaps start implementing health policies to make things better for our patients. Thank you.
Gracias, professor. I'd like to invite Dr. Mauro Guilovissa from Moçambique. Obrigado, Mauro, por sua presença.
Obrigado, professor. Para falar em português? Gostei do convite.
Thank you, Professor. I'm going to talk in Portuguese, and thanks for the invitation.
Okay, thank you for you inviting. It's an honor to be here. And there is many things to talk here, because we here in Mozambique, we have a very challenging issues to do. But I want to start with something that I didn't hear from here about the mentorship and education. I can say by my example, in my country, in Mozambique, we didn't have a program or any discipline about oncology in our formation. We talk about faculty, the residence of surgeons. We don't have that issue. And what starts here in my country for my colleagues, the interest of oncology and surgery, was the courses started in IPO in Portugal from Dr. Lúcio Lara in 2021. So that course made a lot of us surgeons start to be interested in the oncology. So the mentorship, I think, is the big issue in the countries like mine, because the oncology, you cannot find that in our books, in our lessons. You cannot find. You just study this in the pathology, somehow, somewhere in the faculty, and I think it's very important for some kind of countries. And this mentorship, you can extend to the GPs, general practitioners, because we don't have data of that, but the 100% of our patients that came to the surgeon, it came with complicated cancer. You call about obstruction. Understand me? Okay, it's fine. I'm trying. Yeah, obstruction,
okay.
Dysphagia, the icterus, icteria. Okay, so we our 100% patients came with complications. But I cannot show you with data about that, but like a surgeon in emergency room, in the surgeon, we find that patients. We don't have a patient that come with early cancer, okay, as asymptomatic, not pain, not nothing. You don't have that patient here. So that mentorship in education is very important here. So what you see, that that patient that came late here, they used to arrive at hospital 1 year, 2 years ago with pain, some pain in abdominal pain, some weakness, loss of weight. So what you saw, that general practitioner or general doctors don't know about cancer, about the symptoms of cancer, that early symptoms of cancer. So what we did, we introduced the courses and formation, like as surgeons, we introduced the courses and the information for general practitioners, the general doctors, internists, and everyone, that people once they see one signal that make suspicious of cancer, they refer to us. So that mentorship, we think, is the very, very mentorship in education in our country is very, in our country, in a lot of countries, is very important, because a lot of people, they can still with a patient with pain, in gastric pain for 1 month, 2 months, 1 year, 2 years, and do nothing. That just take omeprazole and something else, and never think about cancer. This is the first thing that I think that we have to, we must think about the mentorship and education for cancer to spread the law for a lot of people. And another thing is, I think we can help our colleagues to do biopsy. For example, breast biopsy, prostate biopsy, some tumors biopsy. Because if you send a patient to biopsy, they took almost 1 month, 2 months to make the biopsy. And also to diagnosis, it takes 1 month. So we introduce here in my hospital the biopsy made by surgeons. And this reduce a lot of time to diagnosis. And we are fighting here, like a general surgeon, to make endoscopic GI, the endoscopic GI. Endoscopic GI, we think in my country, in a lot of countries in Africa, in some countries out of Africa, there are small numbers of gastroenterologists to make endoscopic GI. Okay, so somehow we wait for a lot of time to do endoscopic. 1 week, 2 weeks, 1 month, 2 months. And for example, my country, we have only 20 endoscopic gastroenterologists. So it's difficult to make endoscopic triage, endoscopic diagnosis. So we think since 3 years, 4 years, that surgeon must learn to do endoscopic, gastrointestinal endoscopic. We try to search a lot of countries in India, in Portugal, and even in Brazil, because we feel that we need to do that, okay? Because we have a patients that, okay, this is a small sign of cancer, but we have to investigate, but we don't have endoscopic gastroenterologist here. So we think that important role for surgeons is to learn about endoscopy exams. Okay. Okay, and to close to finish my intervention here, to talk about GP, general practitioner, to include that people in our meetings. We introduced them in 1 month, 2 months ago, and since then we were able to find more than 12 cases of cancer, because they used to have a cancer with dyspepsia, a patient with dyspepsia, a cancer with tumor, still investigation, and that and what. And since we invite them to our group of surgeons, we found more 12 cases of cancer that they still not interesting about. So this is my point, and thank you, Rodrigo.
Thank you, Dr. Mauro. Muito obrigado, Mauro, por sua participação. Now I'd like to invite our Brazilian leader, Dr. Paulo Henrique Fernandes, for the closure of this part of the section, this part of the debate. And then Felipe will run the works. Thank you, Paulo, for your participation here.
Hi, everyone. Hi, Rodrigo. Thank you for your kind invitation. It's a great honor to represent the Brazilian Society of Surgical Oncology in this important global discussion. In fact, I would like to ask a question to Professor André. Dr. André, thank you for your excellent presentation. Given the complexity of cancer treatment systems, which require coordination between patients, doctors, and healthcare institutions, in our country, oncological surgeons are concentrated in the largest cities, which increase the complexity. What do you think would be important for oncological surgeons to participate more in the formulation of health policies at the governmental level and to contribute with leadership in higher education?
Dr. André.
Thank you, Paulo, for the question, and I think it's very important. As we saw from the different presentations and the different comments, you have the health system approach that, drives policy. And also you have, the important role also of the surgical oncologist inside the hospitals, right? Leading the multidisciplinary team and discussion. As we know, right, there are way more surgeons than oncological surgeons. And if we want to decentralize diagnosis and accelerate, the process and the patient to come an early diagnosis, we need also to see how oncological surgeons could help general surgeons and other specialists to do a proper diagnosis, right? So I think this, as you said, high education and even, education among surgeons, how can we promote early cancer diagnosis, helping the identification of the signs and symptoms. And then comes how we can influence the referral pathway, right? How can we influence that part and the policy? I think this is always the hardest, but if you begin to train all the primary, secondary, and tertiary care, around cancer and restructure the pathway, naturally will come, the policies changes. I have been trying to implement cancer screening programs, and all comes back on how you restructure your referral pathway, your health system to have a clear, continuum of care from getting the symptoms to diagnose and the treatment. And I know that the Minister of Health in Brazil is at this stage of design, right? A linha de autosuspeição. It's kind of the high suspicious path. And I think it's the moment for the surgical oncologists in Brazil to have an influence on how that should be put together. And I think this is a window of opportunity that you should really see how to get involved in this crucial moment. We want people that know about the disease to be part of that discussion. That would be my suggestion, if you will. Thank you.
Thank you.
Thank you, André. Paulo?
Thank you.
No more questions. So, Felipe.
Yeah, okay. Thank you, Rodrigo. Thank you for moderating this. It was very important. Great moment here. And thank you, André. I agree completely with you, and thank you, Mauro, and all that commented and showed the difficulties you may see in your region, your country. And for sure, most of the diagnosis could be made by general physicians or suspicious symptoms, actually, right? Remember that even those countries, high-income countries that have prevention and screening systems, most of the diagnoses are made by symptoms. There's data shown from England and some others, right, André? So this is really indeed very important. And so I think that this is why we're discussing this here. We have a role not only us directly, but in the education, probably in sharing the knowledge we have with general surgeons, general physicians, the community, make it awareness for the population too. So, and André, I'm happy you are here, happy Dr. Bausch, happy all you are here, because I believe this is probably one of the first discussion in a surgical event about discussing deeply about prevention, detection, and the role of the surgeon in the system. Because I think one of the most important points here is that if you have many barriers during the journey of these patients, you may have early detection, but this patient will not arrive to the curative treatment, as it was very well shown already. So it's not only detection, it's how to take out the barriers in the system so the patient can arrive in a good moment. So I'm thank you very much. I'm very happy and honored to be here. I will give maybe 1 or 2 minutes Dr. Bausch to give his final words too, once me and André already said something. Please, Dr. Bausch, and then Alexandre will finalize the meeting. Would you like to say some final words, Dr. Bausch?
Oh. So I believe that strategies are global. The implementation is local. And having these discussions is very important. We're undergoing a transformation in cancer. At a public health level, cancer is increasing. It's occurring at a younger age. And unless governments and individuals get into screening and prevention, it's going to affect their gross national product because it will impact the productivity of the workforce. Younger people are going to die, or people are going to spend a lot of money taking care of advanced disease. So there's a cost benefit that we need to be doing with the IIRC and us collectively in making the case for cancer prevention and early detection. I think prevention and early detection are handmaidens because we want to identify the at-risk individuals before they get cancer and have them both do prevention, including lifestyle changes, losing weight, exercising more, drinking less, and getting into prevention, chemo prevention, and consideration of risk reduction surgery, and at the same time into screening programs so that if they're going to get cancer, it will be at an early age. So I think we should collectively, as a world group of surgeons, because we understand primary disease better than any other specialty, should be the leaders in developing the strategies, the leaders in the messages, using outlets like the World Society, like the International Society of Oncology Prevention, the UICC and the World Cancer Declaration, and the IARC. And I think if we have a common message for strategies and make a case for the cost benefit and of this, that we can start to get people to think about where they're spending their money. Remember, it's not that this is expensive. It's where we spend our money. And we're either going to spend more money on advanced disease, or we're going to start putting more money in the front end of cancer delivery with prevention and early detection.
Okay. Every time we meet, the one certainly I have is that the WSSO should have been created a long time ago. We all know how to solve the biggest part of this huge problem called cancer, but we are on the front lines. In the high time, we put pressure on those who makes the laws and the public policy around the world. We have now reached the end of our webinar. I would like to thank once again all the speakers and everyone who had the opportunity to be with us today. For for any reason, were unable to attend, the recording will be available on our YouTube channel. I also like to take the opportunity to announce our next event that will be on April 2022 at 10:30 a.m. Brazilian time at Tomor Board host speakers for the 5 continents. I invite everyone to join WSSO, the World Society of Surgical Oncology, which brings together cancer surgery from all over the world. Please take part in your event, scientific committees, and guideline initiatives. Thank you.
Thank you, guys. Thank you all. Thank you all.
Thank you. Bye.